I told everybody this morning they better watch out because I was pretty excited. This may be my one and only time I get to lecture this semester since I'm in a different position now. So, chapter 14, acid-base imbalance. You guys should have learned how to interpret ABGs this morning, so you should be feeling a little bit powerful with the knowledge you gain. All right. When we think about acid-base balance, okay, you need to think that that is happening constantly in the body. Okay, it's going on as we speak. Okay, and there's basically 3 lines of defense. Okay, for acid-base balance. Okay, number 1, we have buffers in our blood that are working to keep the pH between that normal level of 7.35 to 7.45. Okay, and when we talk about that, we're talking arterial blood. Okay, so that's our first line. That's happening constantly, so it's instantaneously. Okay, the second line of defense is in our lungs, our respiratory system. Okay, and that kicks in just minutes. So if I said, let's all run up to the soldiers' monument up on the hill, and the first person back gets an A in the class and they don't have to take any of the tests. Okay? What would our respiratory state be when we all got back? Because it's like 102 index outside. What would our respiratory status be? Would it be like it is sitting down right now? No. How would you be breathing if we did that?
Accelerated already.
Right? Okay, we'd all be out of breath. Okay, that is your acid-base buffer system in action. Okay, our lungs will either speed up the respiratory rate or it'll hold on to our respirations. Okay, so that's our second line of defense. And then our third line is our kidneys. Okay, and they play a role in bicarb and hydrogen ion excretion. Okay, so acid-base balance, okay, I already told you our normal pH, we want it to be 7.35 to 7.45. Okay, and what we're looking at is the hydrogen ion regulation. Okay, we have either too much or too little. Okay, the chemistry, we have acid, bases, and buffers. Okay, when we look at acids, we have the release of hydrogen ions when they're dissolved into water and body fluids. Our bases, so our buffers, can react either as acid or base. Okay, and our bases bind with the hydrogen ion in solutions that lower the amount of free hydrogen ions so that it's not as acidic. Okay, and our basic thing that we're going to look at for acid-base is always HCO3 and CO2. Okay, so our bicarb and our CO2. Now, a lot of times you're going to have that PaO2. Okay, we don't really need that to evaluate what our patient's acid-base balance is. The 2 things we need to know about are the HCO3, the bicarb, and our CO2. Okay? So homeostasis depends on that consistent production of hydrogen ion and then CO2. Okay? We should have normal breathing, okay, so that we can get rid of our CO2. As I mentioned, buffers are our first line of defense. Okay? Common buffers, just so you're aware, phosphate, proteins, albumin, and globulins. Okay? Plasma proteins. Then we look at the respiratory system, okay? And I kind of mentioned this already. Our second line of defense is our brain gets sent that message that says the buffers aren't doing their job. The lungs are going to have to kick in, okay? And then it tells us if we need to increase our ventilation or slow our ventilation down, slow our breathing down, depending on what's happening, okay? This picture should be in your book. I don't remember what page. $265? Okay? So if you look at that, when we have decreased rate and depth of respiration, okay, we're going to have increased hydrogen ion. Okay, an increased rate of respiration, okay, decreased hydrogen ion. Okay? I kind of already mentioned this, okay? Our kidneys, that third line of defense. Kidneys, so your buffers happen instantly, your respirations happen within minutes, okay? But then it takes a couple days, okay? This says 24 to 48 hours, okay? 2 to 3 days before your kidneys start to kick in, okay? We start to see acids, and then ammonium also starts to form. When we start to have the acids and the ammonium start to form, that's when we can start to see some changes in our patient, okay, especially with cognition. And we'll get to that when we start to talk about what kind of cues, okay? So when we're talking about acid-base imbalances, it's really important for you to view this as I'm a detective, okay, and I have to figure out what's causing my patient to have an acid-base imbalance so that I can correct it, okay? Because most of our acid-base imbalances can be corrected, okay? Now, sometimes if we have a patient who is in multi-system organ failure, that poses a problem where they have that mixed. Okay, you guys remember seeing the mixed acid-base imbalance? They're both a respiratory and a metabolic in the video. Okay. So with compensation, the body attempts to correct the blood pH changes. Okay. pH less than 6.9 or a greater than 7.8 is usually fatal. When might we see those types of abnormalities? When would you see a pH that out of range? What kind of conditions?
Stomach cancer.
Okay, so a patient with like terminal cancers. What else? Kidney disease. Okay, end-stage renal disease. What else? I can tell by your eyes you want to tell me something.
I was going to say sepsis.
Sepsis, yeah, sepsis. Anything? Cardiac arrest. What about a diabetic? Diabetic. Okay. Just this last fall, my oldest nephew's daughter and my oldest niece's son were both diagnosed within just weeks of each other of having juvenile diabetes. Okay? Their symptoms were flu-like, but a lot of respiratory symptoms. Okay? pH way out of whack. Okay? But we're in a pandemic, aren't we? Okay? So their first thought was, with both these kids, oh, they've got COVID. Okay, and it wasn't until they got their blood sugars back that they were like, oh, no, they don't have COVID, they're diabetic. And we need to get them some insulin on board right away, okay, before they go into DKA completely, okay, into a coma, okay? So we have our respiratory compensation, okay? Both of them were having respiratory complications, okay? And then kidney compensation, okay? And that will come days after, okay? So with acidosis, it's hugely important that you guys understand the conditions that cause each of these situations, okay? So also posted on Canvas are these kind of goofy little handouts. Did you guys see those? Okay. I like any resources that make imprints on my brain. Okay. So when we look at Acidbase, okay, and if you have this with you, okay, the first picture is a picture of somebody in respiratory acidosis, okay, and the little character there is saying, I can't breathe, okay, so we see this most commonly in patients who have breathing problems and patients that are older and have breathing problems. Our patients that have COPD, chronic obstructive pulmonary disease, okay, COPD. What might we see happening in that patient? What are the cues? Okay, and as you start to progress through the remainder of the program, you're going to hear some terminology that may be a little different. Okay, cues is one of the words. Okay, because you guys are going to be one of the first groups that take the revised NCLEX exam. Okay, and it's called the Next Gen NCLEX. So when you guys take your boards, you're going to have a different style of question, okay, that really focuses on your ability to critically think and make clinical judgments. Okay, and they focus on cues. All right? Looking at your patient, assessing your patient, looking at the data from the lab, the vital signs, all of those things. Okay? So our cues would be hypoventilation. What's the respiratory rate? Do we have rapid, shallow respirations? Do they have a headache? Are they hypoxic? Are they disoriented? Okay, your brain needs blood, oxygen, and glucose to function properly. And when there's an alteration in any one of those three things, your brain doesn't work right. Okay, we can almost add sleep to that, but that's a whole nother thing. Okay, but if I have an alteration in oxygen level, okay, because of acidosis, I might be confused. That would be one of the early signs, the early cues. Okay? Then we may see a change in their cardiac output. They may be weak in their muscles. Okay? So those are things we want to look for in our patients. Okay? And with metabolic acidosis, we look at hydrogen ions and bicarb. So there's either too much hydrogen ion and we're not getting rid of it, or we don't have enough bicarb, or we're getting rid of it too fast. Okay? With our respiratory acidosis, our respiratory function is going to be impaired, just like we talked about. Okay? You're going to have a reduced exchange of oxygen and CO2. And that exchange means that we're going to hold on to the carbon dioxide. Okay? So we're going to see respiratory depression. So if I have a patient, you guys are going to get ready to go to clinical, and you're going to be on a med-surg floor. You've got a patient who just came up from the OR. Why do we put them on a pulse ox?
That's the anesthesia because I think that's something.
Yeah, anesthesia can alter the respiratory rate. Okay, so just because they come up to the floor doesn't mean that they are fully awake. Okay, so we have to watch the respirations because they can go into respiratory depression. Okay, because of the after effects of anesthesia. It may not be worn off yet. Okay, so we've got to watch for that. Anytime the respirations are inadequate, okay, so if I've got somebody whose respirations are 10, I'm going to worry about respiratory acidosis. Okay, are they holding on to carbon dioxide? Inadequate chest expansion. What kind of patient would you think might have inadequate chest expansion?
CHF.
CHF? What else?
Pneumonia.
Pneumonia. What else? Two big ones this year.
COPD.
Kind of linked in with pneumonia. What if I've had a big abdominal surgery? Do I want to take deep breaths? No, I don't. Okay, I don't want to do anything. I just want to lay there. Okay? And your trauma patients, okay, especially if they have had a thoracic, okay, bruising, fractured ribs, anything like that, okay? Airway obstruction. Okay, so when you see airway obstruction, okay, don't just, like a lot of people are like, oh, but somebody who's choking. Okay, but airway obstruction, okay, COPD, asthma, okay, all of those things, disorders that would cause a narrowing, okay, anaphylaxis, okay, could cause an airway obstruction. Okay, and then our reduced alveolar capillary diffusion. Okay, so in your book, when you guys see these types of things, respiratory depression, I don't want you to just memorize respiratory depression. Okay, you need to take it one step further and say, okay, what kind of patients might experience respiratory depression? Who would I see this in? Okay, does that make sense? Okay, that's taking it from just general knowledge to application. And that's where you guys need to be for testing. Okay? So, respiratory depression, drugs. Okay, I've overdosed. Alcohol. Respiratory depression, head injury. Okay? So one of the prime examples of a metabolic and respiratory acidosis patient is that patient who has diabetic ketoacidosis and COPD. Okay, so when you looked at that final acid-base balance on the video where they had that mixed acid-base imbalance, okay, a person, if you want to link that to diagnoses, somebody who is in DKA and has a history of COPD. Okay, that's the type of patient where you could see that mixed acid-base imbalance. So when we are assessing, okay, and I want to draw your attention, what does this slide say? Recognizing cues. Okay, your assessment is cued. Okay? Your age, their nutrition. Okay, what kind of symptoms are they currently having? Okay, do they tell you, I've had vomiting for 3 days? I've had diarrhea for 2 weeks. Headaches. Are we seeing behavior changes? Are they hard to arouse? Okay, those are all things that we need to know about in order to formulate, okay, what's going on with our patients? Okay. Then with our physical assessment, we're going to look at their cardiovascular status. Okay. What do we need to know about in regards to their cardiovascular status?
Like you said, if they got any problems with their chest, because that caused like the problem with the chest expansion.
Okay, so CHF, chest expansion. What else? What else tells us about a person's cardiovascular status?
Blood pressure?
Blood pressure, heart rate. Okay, those tell us a lot. Okay, then we can put them on a monitor, can't we? Okay, and look for irregular heartbeat. Okay? Central nervous system and neuromuscular. What kind of central nervous system things do we need to be on the lookout?
Are they oriented?
Yeah, are they oriented? Are they confused? What did you say? Peyton?
I said
Alert?
alert. I was just saying
Alert? Okay.
Are they able to?
Yeah, are they able to follow commands? Okay, because a lot of times they may be alert, but they can't converse with us, or they're really confused and mixed up. They don't know who they are or where they are. Okay, and that can all be because of an acid-base imbalance. Okay, neuromuscular status. Okay, with acid-base imbalance, we can have altered potassium levels. We can have hyperkalemia. So we can see sometimes irregular heartbeats, but we can also see some kind of bizarre neuromuscular activity as well. Okay? Then we want to look at their respirations. Okay, what's happening there? Because we know that our lungs will either compensate by trying to burn off all that CO2 by increasing our respirations, or if we don't have enough, they're going to hold on to it, so we'll have slow respirations. And then we want to look at their skin. Why would we want to look at somebody's skin in acid-base imbalance? Why would somebody's skin be important?
If there's cyanotic and it's not, they're not breathing right.
Excellent. Yeah, perfusion. Perfusion. So you want to look at their skin. Are they pale? Are they diaphoretic? Do they have good cap refill? Okay, because that tells us if they're getting good oxygenation or perfusion. Okay, now, a step forward to that is, then we also want to look at their skin. Is it dry? Is it flaky? Do we see like these little crystals and sweat beads on them? Because that could be an indication of end-stage renal disease. Okay, so if we're starting to see some of that, that tells us we've got not only respiratory involvement, but kidney involvement too. Okay? So then, psychosocial. Okay? Cognitive changes may be one of the first signs of acidosis. Okay? Remember, blood, oxygen, and glucose. Your brain has to have those three things. Okay? And when we don't have the right amount of those, we get a little wonky. Okay, we don't act right. Our cognition gets altered. Okay, so our lab assessment, this is just kind of a repeat from this morning. You should have learned this from the video. But metabolic acidosis, you're going to have a pH less than 7.35, a bicarb less than 21. Their O2 may be normal, and don't always count on this potassium information. Okay? Not every person that has a high potassium level is going to be in metabolic acidosis. Okay? Sometimes they just have a high potassium level. Okay? So don't link those two things together as cause and effect. Okay? With respiratory acidosis, okay, we've got a pH less than 7.35, low PO2, high CO2. Our bicarb, usually normal in acute respiratory acidosis, but we'll see it elevate when we have a chronic respiratory acidosis, and that's because your kidneys are kicking in. Okay? Your kidneys kick in, and that's where we start to see an elevated bicarb. So, we're going to analyze cues and prioritize a hypothesis. Okay? Now, that is the new lingo, okay, for what's my nursing diagnosis going to be. Okay? So the priority client problem for a client experiencing respiratory acidosis, gas exchange. Gas exchange. Okay, so if you guys go into clinical and you have a patient who is in metabolic acidosis or respiratory acidosis, okay, one of your primary nursing diagnoses should be reduced gas exchange resulting from the underlying pulmonary disease. Okay? So if we're looking at metabolic acidosis, okay, we're going to look at what's causing our acidosis. Okay? Number one, it's going to happen in our diabetics, and we need to get them some insulin. Okay. One of the next most common, okay, is rehydration and antidiarrheals. Okay, because the next most common cause of metabolic acidosis that we see is prolonged diarrhea. Okay, and this just happened to my cousin this last week. Okay, she gets to come home from the hospital today. My sister's picking her up. But she had spine surgery about 2.5 weeks ago. Okay, and they did a procedure where they went basically both anterior and posterior. So they went in anteriorly and attached plates to her spine. And then in surgery, they flipped her over and put plates at the top, at the posterior part. Okay, so she has incisions in both places. But about, what's today? Tuesday. So about a week ago, okay, she started with some nausea, vomiting, diarrhea. Okay, at first she thought it was her pain medicine. Okay, and then she was like, oh my God, do I have COVID? Okay, but it got so bad that they actually took her by ambulance. Okay, prolonged diarrhea. Okay, metabolic acidosis. Okay, they gave her fluid, they gave her potassium. Okay, and she gets to go home. And she doesn't have COVID. So she was really excited about that. Okay, now she's like, do you think I got it while I was in the hospital? I don't know. Probably not. I think you'll be fine. Okay. With respiratory acidosis, what do? Okay. We look at things that are going to improve gas exchange. Okay, drug therapy. Okay. What kind of drugs might a person need to improve their respiratory status? They're in respiratory acidosis. What kind of drugs?
Bronchodilation.
So bronchodilators. Okay. What else? If we have inflammation, what might we see? Steroids. Steroids. Okay. If I'm septic, antibiotics. Okay. Oxygen therapy. Now, one thing, and you guys probably already learned this, but I always want you to remember, when we have patients who have COPD, giving them more oxygen is not going to automatically make them better. Okay? With chronic obstructive pulmonary disease, okay, they have kind of this max capacity, And it doesn't matter how much oxygen we give them, they're not able to process it. Okay? So a lot of times, we may only have them on 2 liters, 3 liters. Okay? We're not going to put them on 4, 5, 6 liters of oxygen. Okay? Because they've already maxed out on their capacity. Okay? And I think a lot of times families and sometimes students are like, well, they've got COPD, but their O2 sat's low, so we just need to give them more oxygen. That's not going to fix it. Okay? Their oxygen carrying capacity is maxed. Okay? Pulmonary hygiene. What is pulmonary hygiene? What do we mean by that? Coffee? IS? Anything else? Deep breathing? Turning? So that turn, cough, deep breathe. Okay. We also see this thing, and it's called chest percussion. Okay, Brenda, can I use you as a model? Okay. So one of the things we see, okay, I'm going to have you want to stand up here. Okay, so sometimes if we have a patient, so what we're seeing with our COVID patients, okay, is tummy time. Okay, we're rotating them on their stomachs, okay, to help with secretion and changing of position for alveoli expansion. Another thing is called chest percussion. Okay, so you'll see respiratory therapists come in, they'll cup their hands, and then they'll just come and almost like beat on the person's back. Okay, and sometimes it's for like 15, 20 minutes. Okay, thank you. And they'll do that to loosen those secretions. Okay, now, when we have spinal cord injury patients, okay, somebody got really, really smart and invented a vest that they could put the vest on the patient and it kind of vibrates and has that percussion so that they could loosen those secretions. Okay? So when we say pulmonary hygiene, it's the turn, cough, deep breathe. The IS could be chest percussion, could be the percussion vest, it could be the tummy time. Okay? For the rotating. Okay? And then the final thing there is ventilatory support. Okay? And that is exactly what it sounds like. Okay? They're not able to breathe on their own effectively, so we have to put in that breathing tube, so mechanical ventilation. Now, the thing to remember, okay, these are not things that people manage at home. Okay? They are in the hospital, they are critically ill, and they need to be managed there and then can go home. So our outcomes, we want to maintain adequate gas exchange. We want that pH above 7.2, but closer to 7.35. Their PaO2 level at 90. Okay, and then the CO2 less than 45. Questions before I go into alkalosis? Discussing, not physically, right? Okay. So with the patho of alkalosis, we have excess bases, especially bicarb. We see a decrease in the free hydrogen ion level, and our pH is going to be greater than 7.45. Okay? With relative alkalosis, our bases aren't going to increase. Our acids decrease, creating this acid deficit. And we have a relative base excess of alkalosis resulting from over-elimination or underproduction of acids. How might we over-eliminate our acids? Vomiting. Okay. Think about your belly button. Okay. We house acids above our belly button, and we house bases in our GI tract below. Okay, so if I have diarrhea, I'm getting rid of all my bases. Okay, if I have excessive vomiting, I'm getting rid of all my acids. Okay? So with our metabolic acidosis, we have an increase of bases or decrease of acids. Base excess is caused by excessive intakes of bicarb, carbonates, acetates, and citrates. What kind of medicine or drugs is that describing?
Antacids.
Antacids, yeah, Tums. Okay. And anybody have a grandma that if you ever got sick, she'd go get baking soda, put it in water and tell you to drink it? Yeah, baking soda. So we have an acid deficit that's caused by a disease process or medical treatments. Okay. Can you think of any medical treatments that might cause us to lose some of our acids? What kind of treatments? Can you think of anything?
Suctioning.
Suctioning? Yeah, prolonged suctioning. Okay, what else? So like an NG? Okay, an NG. What if I'm getting chemo? Makes me want to throw up, and I throw up a lot. So anything, think about any disorder that would make you lose your acids. Okay? So with respiratory alkalosis, we're going to see an excessive loss of CO2 through hyperventilation. Okay? So this is that rapid blowing off of CO2. Okay? And our hallmark ABG, okay, you're going to have an elevated pH and a low CO2. Okay? So we want to recognize our cues. So we can sometimes see those low calcium levels and low potassium levels with alkalosis. So then we look at what are our CNS signs. Are they confused? Do they have a headache? Are we seeing neuromuscular and cardiovascular signs? What's the respiratory? And our take action. What are we going to do? We want to prevent the further loss of hydrogen, potassium, calcium, and chloride. Okay, so we got to figure out how they're losing it so that we can stop that process from happening. And then we want to restore fluid balance. Okay, Darla talked fluid restoration already. We're going to monitor for changes. What kind of changes are we going to watch for?
Respiration changes.
Changes in the respiration. But what else?
Electrolytes.
Electrolytes. Yeah. Okay. Because if we're going to restore the balance, okay, don't we have to know what those levels are? And we have to know if they're getting better or worse. Okay, so we're going to have to look at our lab values. Okay, and with that, you need to think about, okay, if my patient's potassium is high, what kinds of signs and symptoms might I see? If my patient's potassium is low, what kinds of signs and symptoms might I see? Okay, same with calcium. What am I going to see in the patient that has a high calcium versus a low calcium? Okay? We want to provide for their safety. So what kind of things might we have to do? do? How are we going to provide for their safety?
Side rails if they confused, or like
Loud?
side rails if they like disoriented.
So side rails,
Or middle one.
gate belts if we're walking them. Okay, tell them not to get up by themselves. Okay, escort them to the bathroom, stay with them. Okay, the cardiac monitoring. Okay, and then we're going to stop the treatments that have caused the alkalosis. Okay, we're going to give them the fluid and electrolyte replacements and any type of drug therapy that we may need. Okay, so then let's go through a couple of these questions. Okay, there's more questions. If you register with your book and go to each chapter, there are NCLEX prep questions that I would encourage you to do at the each chapter level. So, chapter 14, there's about 20 to 30. Each chapter has about that many, okay? When you look through your text, there's these little green boxes, okay? And they'll say, like, NCLEX examination challenge. There are these, like, challenge questions. Yeah, what page is that? So, 266. There's an example. Okay, those answers, if they're not in the back of the book, they are,
I think they're in the back.
are they?
Yeah.
They're also on that resource too. Okay, it looks like those answers are in the back. Okay? All right, so here we have this patient. They have a history of COPD. They're brought in to the emergency department. What acid-base imbalance do we anticipate? So we have a client with a history of COPD. They're brought to the ED with respiratory depression. What acid-base imbalance do we anticipate? Respiratory acidosis, okay? Because we know if I have respiratory depression and a history of COPD, what's happening to my hydrogen ion? It's going to go up because, why? I'm holding on to CO2. Okay? All right, we got it right, didn't we? Okay, so respiratory acidosis results when respiratory function is impaired and the exchange of oxygen and carbon dioxide is reduced. This problem causes a CO2 retention, which leads to the same increase in hydrogen ion levels in acidosis. Okay? So question number 2. The nurses evaluated the laboratory assessment data on a client with uncontrolled metabolic acidosis. What finding does the nurse anticipate? What would we anticipate? Okay, a pH of 7.40. What's a pH of 7.40? Normal. So we can eliminate that, right? Okay. An O2, a PaO2 of 98. That's normal, isn't it? Okay. 98 to 100. Okay. A bicarb of 38. Or a serum potassium of 5.7. What lab assessment might we expect? The potassium. Okay? The potassium. So, metabolic acidosis is reflected by several changes in the ABG values. Okay? Typically, our pH is going to be low. The bicarb is going to be high. Okay? Typically, you're going to have a normal O2 level. Okay? We often see an elevation in the serum potassium because the body is attempting to try electroneutrality during buffering. Okay? So with buffering, that's where we start to see that 7.5? No, 5.7 potassium. And then, is this the last one? The nurse is reviewing the orders for a client with COPD who was admitted for chest pain. Laboratory results indicate they put too much, haven't they? Mild respiratory acidosis. Which order would you question? Okay, we just talked about this. Okay? COPD, are we going to encourage fluids?
Yes.
Yeah? Why would we encourage fluids?
To help with secretion.
Yeah, thin the secretions. Okay? Keep the head of the bed elevated. Yeah, most of the time somebody who has COPD can't tolerate laying flat. Those are the people who, they're going to tell you that they're sleeping in their recliners. They use multiple pillows at night. Okay? Oxygen therapy, 4 liters per minute as needed. Do we want that? No. Why? What did we talk about?
Because they're at their max.
Yeah. Too much oxygen actually causes a decrease in their respiratory drive. Okay? And when we have that decrease in their respiratory drive, they can actually go in to respiratory arrest.
Hallway.
Okay. Okay. And then bed rest with bathroom privileges only. Yeah. We don't want them to fall. Okay. So again, C, we don't want to over-oxygenate them. Okay, so bed rest is going to help them conserve their energy. The upright position, high Fowler's, helps increase lung expansion. Increasing fluids may decrease the thickness of their secretion. Oxygen therapy helps promote gas exchange for clients with respiratory acidosis. However, we're going to use caution when we're giving it to patients with COPD and CO retention because it can cause a decrease in arterial oxygen level. Okay? Too much oxygen in these clients will decrease their respiratory drive and may lead to respiratory arrest. Okay, that's hugely important for you to remember. Okay, clinically. Okay, because a lot of times people's inclination is, oh, they're having trouble breathing, let's give them more oxygen. Okay, it actually puts them in a worse condition. Okay. All right. Questions? All right.
Jen?
Yeah. Oh.
Are those what our test questions are going to kind of be like, the ones at the end of the slide that we just did?
So more like that. Yes. Okay. So they're not going to be, what's a normal ABG? Okay. You're going to have data that you're going to have to interpret and calculate that. Okay. So you will have to interpret at least one or more ABGs on your test. Okay. I would encourage you. You have access to Kaplan. Okay. You can build quizzes in Kaplan by selecting the topics. Okay. Fluid and electrolyte. Go in and build those quizzes. Okay. Use the in-class questions that come with your book. Okay. Look through, do all of those in-class examination challenge questions. Okay. And with fluid and electrolyte, there's a component of memorization, but with that memorization, you have to then take it to the application level. Okay? You have to understand, okay, what kind of conditions may cause a patient to have hyper or hypokalemia. And how do I fix it? Okay, so if you're a visual person, okay, go to these handouts, okay? There's different ones, okay, that can kind of help, okay, because just like with those first couple slides, okay, it's going to give you something generic, okay, but then you have to think about, okay, who's this going to happen in? What kind of medications? Why am I giving them that medication? Okay, how am I going to monitor them after for side effects or for improvement? Okay, so you're looking at those cues, okay, to figure out what's your action going to be. Okay, and those cues are the lab values, your assessments, all of those things. Okay. Other questions? Okay. That's all the content for your first test. Okay. First test is when?
Next Tuesday.
Next Tuesday, a week from today. Okay. So